Good evening, dear friends. Namaste. Welcome you all for this Gapio Aries International Lecture Series on newer medicines for weight management. Today we have an eminent faculty, Dr. Arun Prasad, will speak on newer medicines for weight management. I have a great pleasure introducing our chairperson for this session. Dr. Tarunji is head of the hyperbaric medicine at Apollo Hospitals, New Delhi, and is also the father of modern hyperbaric medicine in the country. Is a well-known here in the country and is also examiner for postgraduate studies at Mumbai University. And he has numerous publications nationally and internationally, and he's also been in the LIMCA Book of World Records. And he has landmark publications on high altitude diving in the Himalayas at Ladakh, and is well recognized and referenced at British Journal of Neurosurgery and hyperbaric oxygening in traumatic brain injuries. Over to Dr. Tarunji for taking over the session.
Thank you, Dr. Jayaprakashsai. It's a pleasure. And thank you, Gapio, for giving us an opportunity to interact with you and with all your members across the country and across the world. Our eminent speaker today is Dr. Arun Prasad, and it's my proud privilege to introduce him. Dr. Arun Prasad is a clinical lead and senior consultant in GI, bariatric, and robotic surgery at Apollo Hospital, New Delhi, and has over 36 years of surgical experience. He has experience of performing over 10,000 laparoscopic surgeries that include 6,000 laparoscopic cholecystectomies, 2,000 laparoscopic hernia surgeries, 2,000 thoracoscopies, and 1,500 bariatric surgeries, and 500 robotic surgeries. Dr. Arun has the privilege of doing numerous world's first laparoscopic, thoracoscopic, and robotic operations. He is former president of Obesity Surgical Society of India and president of the International MGB-OAGB Club for Bariatric Surgery. He is also the editor of the Journal of Minimal Access Surgery, World Journal of Gastroenterology, as well as reviewer of surgical endoscopy and obesity surgery and board member of the EC Journal of Gastroenterology. He is currently the vice president of ARIS and has published more than 55 papers in various journals. Welcome, Dr. Prasad, and we look forward to your enlightening talk. Over to you.
Thank you, Tarun, for those kind words. And thank you, Gapio, for organizing this meeting. So I'll move on straight to my presentation, and I'll just share my screen. And the topic for today is newer medicines for obesity. So I've been treating obesity since 2004, starting with procedures like gastric band, bariatric surgery, robotic surgery, gastric balloons, endoscopic treatment, and now of late, we've got the options of some new medicines which have been in the news for some time, and a lot of patients are asking for it, and there is a lot of enthusiasm for these medicines. Even the obesity treatment has been a highlight by various organizations and even by the government of India. So when we talk about new medicines for obesity, we are often seeing cartoons like this, which make us wonder what's going on and what are the options for obesity management. We have diet, exercise, which has always been there, good for prevention, and prevention is better than cure, and that remains the same today also. We have behavioral and lifestyle changes which need to be made, medications, which we'll be talking about today, metabolic surgery, which is an option, which we will be perhaps discussing in some other meeting of ours. So in 1950s to 2000, we had medicines like amphetamines, orlistat, sibutramine. But these medications had poor efficacy, high dropout, and adverse effects, so they did not become very popular. 2010 onwards, the rise of GLP-1 receptor agonists, GLP stands for glucagon-like peptide 1 receptor agonist for diabetes, and these medicines were then repurposed for obesity. The emphasis on metabolic benefits and cardiovascular safety. So when we talk about the GLP-1 and GIP, what are they? So these basically enhance insulin and reduces the appetite. We have GIP-1, which is gastric inhibitory polypeptide, which enhances insulin secretion. Then you have dual agonists, which activate both these and have a synergistic effect. The benefits are in terms of satiety, delayed gastric emptying, and reduced cravings. Now, reduced cravings is the highlight of these medications, and that is what has made the medication very popular. What is GLP-1? Just a very brief slide. So GLP-1 is secreted on ingestion of the food from the terminal ileum, and the beta cells, it enhances glucose dependent insulin secretion. It acts on the brain to promote satiety and reduces appetite. It acts to reduce postprandial glucagon secretion. Glucagon reduction reduces hepatic glucose output, and it also works on the stomach to reduce the gastric emptying. And this is basically also the mechanism by which bariatric surgery works. So what GLP-1 does is basically increases the beta cell response and reduces the beta cell workload. Early drugs were there like Saxenda, which was there for diabetes. So liraglutide also came as Victoza at a higher dose, which was used for weight loss. However, these injections needed daily injections. They had side effects and the efficacy was not that high. So what has changed? What changed was the introduction of this medication, which is known as semaglutide, also popularly known as Wegovy and Ozempic. I shall explain the names and the terminology in a while. So the chemical is semaglutide, which was developed by Novo. It's a GLP-1 receptor agonist. Approved for obesity is a drug known as Wegovy at the dose of 2.4 milligram per week. It comes under various names just to prevent the confusion. So while Ozempic is the name of the semaglutide, which is used for the injections which are used for diabetes, Wegovy is the injection at 2.4 milligram weekly injection approved for obesity. Originally for type 2 diabetes, Ozempic 0.5 to 2 milligram per week was there. And also it comes as a tablet. So to add to further confusion, there is a third name of semaglutide, which goes by Rybelsus tablet. So Rybelsus was also used for diabetes. So semaglutide chemical comes under three names: Rybelsus tablet, Ozempic injection for diabetes at a lower dose, and Wegovy injection for obesity, which is at a higher dose. How does it work so well? It delays gastric emptying, so patients feel full longer, acts centrally on appetite regulating centers, reducing food intake. It improves insulin sensitivity and reduces glucagon, which leads to better glycemic control, promotes fat loss preferentially over lean body mass. Now, that is also very important. So semaglutide tablet Rybelsus has been available in India for a while at various doses, and this comes at a cost of almost about 10,000 a month. We'll talk about the cost later. So what are the benefits of semaglutide tablet, the Rybelsus for weight loss? Number one, it's an oral formulation. So only GLP-1 receptor agonist in tablet form, ideal for patients averse to injection. It's a GLP-1 based mechanism which mix natural glucagon like peptide 1, reducing appetite, increasing satiety, delaying gastric emptying. So in other words, it's like a medical form of a bariatric surgery, gastric bypass surgery, where the GLP-1 increases. Significant weight loss, though not FDA approved for weight loss, studies show good weight loss over 6 months, more with higher doses, and now it's got the FDA approval. Cardiometabolic benefits are there, which leads to improvement of HbA1c, lowers the blood pressure and LDL cholesterol, and reduces risk of cardiovascular events in diabetics. Gradual titration minimizes the side effects. So we start with a 3 milligram per day dose and go up to 14 milligram, which allows better tolerability. Better compliance for needle phobic patients can improve adherence in patients unwilling or unable to use injectables. So these are the two medications which I mentioned. Ozempic in the 1 milligram injection, which is used for diabetes, and Wegovy comes as a 2.4 milligram injection for weight loss. Indications: BMI more than 30 or more than 27 with comorbidities. Exclusion: history of any thyroid cancer, history of pancreatitis, gallstones, any retinopathy also. It's an adjunct to diet and physical activity. Please remember, it is an adjunct. So you cannot be giving semaglutide as part of the cereal and hope that everybody becomes thin and slim. What are the clinical outcomes? There have been various trials known as the STEP trials. 5 trials are there, and they've shown a mean weight loss of about 15% of body weight, significant HbA1c reduction, cardiovascular benefit, which is being seen in this drug, is something really very important and very crucial to the success of this drug. Sustained results are seen over 68 weeks. Improved quality of life scores. So if there is a word of caution, you cannot take it and instantly lose weight. It has to be taken over a slow period of time, and it takes time for the effect to work, unlike what you are seeing in this cartoon over there. Side effects are there: nausea, vomiting, diarrhea, constipation. There are serious side effects also, like pancreatitis, gallstones can happen, kidney injury are possible. So tolerability improves over time with dose titration, as I mentioned earlier. So what are the benefits of the injectable? Now, this shows 15 to 17% total body weight loss over 68 weeks, which is the highest among current medications. Long-acting formulation allows weekly injections, improving convenience and adherence. Excellent glycemic control in diabetics and reduces cardiovascular risks. Number 4, it has a strong effect on reducing food intake, increasing fullness, and lowering cravings, which is, as I mentioned earlier, a big hit amongst patients. Cardiovascular protection is there. There is reduced risk of major adverse cardiovascular events. That's the MACE in diabetics and high-risk obese individuals. It has been tested across various age, gender, ethnic, and BMI groups. I believe the trial started some way back in 2001. Now, what's next? So next is this other medication which has come of late and has been the talk of town and has been there in lots of articles, news articles, publications, and that is Mounjaro. So this is tirzepatide, which comes under the name of Mounjaro or Zepbound. Again, like semaglutide we discussed earlier, Mounjaro is the drug used for diabetes, while Zepbound is the drug used for weight loss. This only comes as injectables. There are no oral medications here. It's been developed by Eli Lilly. It has a dual action of GLP-1 and GIP-1 receptor agonist, weekly subcutaneous injections, approved for type 2 diabetes, and also been approved for obesity. That's the ZEP bound. So Monjaro for diabetes and ZEP bound for obesity. These are the two medications. It comes in pre-filled syringes. So benefits, it shows superior weight loss efficacy. It has shown up to 22.5% total body weight loss, the most amongst current anti-obesity medications. Dual action of GLP-1 and GIP targets two incretin hormones, enhancing glucose and fat metabolism beyond what semaglutide can offer. Better fat reduction leads to greater visceral and subcutaneous fat loss, preserving more lean mass. Once a week injection like semaglutide administered weekly, good for long-term adherence. Glycemic control for diabetes, it is highly effective in type 2 diabetes. It reduces waist circumference, blood pressure, triglycerides, and insulin resistance. This also works well with patients with severe obesity, that is more than 40 to 50 BMI, including those not eligible for or ready for surgery. So these are some of the benefits which we see here. Indications of tirzepatide: obesity more than 30 or more than 27 with comorbidity, shown to benefit insulin resistance, lipids, BP, used for diabetics and weight loss. Clinical outcomes: there has been a trial which has shown 15 milligram dose led to a 22.5% weight loss. This is a high dose. We don't have comparative figures of what high dose semaglutide weight loss is there. So it is superior in a head-to-head comparison, but we are still waiting for the high dose safety and weight loss results from the other competing drug. And I'm glad to see we have two options with two drugs competing, and may the best for my patients win. Greater HbA1c reduction in type 2 diabetes. Fast onset, better tolerability profile, which has been noticed. Side effects are there very similar to the other medication, which is nausea, diarrhea, constipation. Appetite suppression can sometimes be profound. Rarely you can see cholelithiasis, pancreatitis. Ongoing safety monitoring is going on. This we have also used with bariatric surgery, the weight loss medications, and there we have found complementing weight loss and glycemic control. So sustaining weight loss after bariatric surgery, GLP-1 receptor agonists may help patients sustain weight loss by reducing appetite and improving satiety. In some cases, patients may experience weight regain several years post-surgery, and GLP-1 receptor agonists can counteract this trend. Many have type 2 diabetes, and GLP-1 RA can improve blood glucose control post-operatively, particularly in patients with residual diabetes or incomplete remission after bariatric surgery. Tirzepatide versus semaglutide versus other drugs. So we've got these list of drugs, and we have gone through the details earlier. Only the first two currently are in use. The bottom four are there in this chart only for a reference point. Weight loss efficacy: oral semaglutide about 4 to 6%, injectable 15 to 17%, tirzepatide about 20 to 22% at the doses which have been prescribed at present. Maybe changing the dose or making some combinations might further improve weight loss with these drugs. But these are the published results which I'm sharing. Tirzepatide shows highest sustained weight reduction with the current studies which are available to us. Monthly cost and availability: Rybelsus, which is the oral medication, costs about 10,000 for 14 milligrams. It's available in India. The cost is approximate. It can vary. There could be about 10 to 20% variation in the cost. depending upon where you are getting the drugs from. Mounjaro is available about 15 to 20,000 is the cost of the Mounjaro injections, and Ozempic is about 20,000. We are not sure. This is pending. So we have lots to look forward to. Zepbound again is pending. We wouldn't know what the cost is, but probably it will be similar to the Mounjaro cost. And this is a study which has shown about its use in post-bariatric surgery patients, where it complements weight loss and glycemic control. After bariatric surgery, also there is a role in the weight plateau, as I mentioned earlier. It can enhance suboptimal weight loss. There are upcoming drugs like retatrutide, which is a triple agonist having GLP-1, GIP, and glucagon. Early trial phase 2 are going on, and it shows about 24% body weight loss in 48 weeks. Potential to replace bariatric surgery in some situations. Side effects are under evaluation. Phase 3 trials are underway. Then there is cagrisema, which is a combination of cagrilintide, which is an amylin analog, with semaglutide. It has a dual effect on satiety and slow gastric emptying. Phase 2 trials have shown about 17 to 18% weight loss. Once weekly injection is what it's coming up with. And Novo is developing this as a successor to Wegovy. So this is what the future looks like. And we are to see how things shape up in future. Maybe we will have a update webinar a year later where we can all share our experiences too. There is a lot of talk about Ozempic face, and this is the reason why these medications should always be taken under supervision of a physician. Firstly, you saw the side effects. There were complications list, some of which are serious. So people should not be taking these medications off the counter. I know it is available off the counter, but that is a dangerous thing. If you don't take it properly, you might, without supervision, you will end up with muscle loss and loss of connective tissue, which is what is being seen on the right side, showing wrinkles, sunken eyes, and a lot of, again, in the news, we've been seeing these kind of pictures of celebrities who have been on these weight loss medications. This is something we want to avoid. How to prevent this? Controlled gradual weight loss. Aim for a slow and steady reduction combined with a high protein diet to preserve muscle mass. Strength training, resistance training, preserving lean mass supports skin tightness and shape. Hydration and nutrition is very important. So is a skincare regime using retinoids, etc. Consider professional skin tightening and aesthetic treatment if needed. There are dermal fillers, and there are a lot of options which are there. So these are the few of the methods to prevent the kind of face we saw in the slide before. To summarize, anti-obesity drugs are revolutionizing treatment. Tirzepatide and semaglutide are the current favorites. GI side effects are common but manageable. Affordability and access are key hurdles currently. Upcoming agents may transform the landscape further. So currently what I see is that oral semaglutide we will be using in mildly overweight diabetics who prefer pill. Injectable semaglutide in moderate to severe obesity, also where CV cardiovascular protection is needed. And tirzepatide for high BMI, where you look for maximum weight loss in these people. Now, the studies have been there for a certain number of months. what happens after you stop these medications is something that will be available to us in due course of time. What we hope that the weight loss leads to a change in lifestyle. So somebody who's obese, morbidly obese, is unable to do exercises. Once your weight reduces, you are able to go to the gym, you are able to get used to a reduced diet over the period while you are taking these medications, and you will continue the lifestyle. The warning here is that once you stop the drug and if you revert back to your original lifestyle, then the chances are high that you will regain your lost weight. So that's a warning there. Ozempic, Monjaro, and Wegovy are the new Greek gods when it comes to food and obesity. With that, I come to the end of my talk. I'll be happy to answer questions.
Thank you, Dr. Prasad. That was highly fascinating, this new world of, weight loss. I think I have a simple question to you, and then I'll request Dr. Jayaprakash to look at some of the questions which have come into the chat box. So do you think eventually we're going to do away with bariatric surgeries? Will, medical obesity management become equally efficient as surgical weight loss, or you think there is a role for complementing each other?
Oh, yes, this is a role for complementing. The more choices we have, the better it is. Initially we had bariatric surgery, then we have endoscopic options. Now the drugs are there. So the status of these drugs are there in certain patients who are not that super obese. So, once the BMI is very high, then that kind of a percentage of weight loss of 15% would not make that much of a difference in, say, somebody who's 215 kgs. But yes, there will be a subset of people who can avoid bariatric surgery by reducing their weight and then by maintaining their lifestyle with the reduced weight. If they don't maintain their weight loss by the improved lifestyle, then they're going to get back to the original situation where bariatric surgeons are always there to help. But yes, it is a good option to try before bariatric surgery. And as I mentioned, that there would be a role that along with bariatric surgery or along with our gastric balloons or endoscopic procedures, we could be giving people medications temporarily to improve their glycemic control, to expedite or moderate their weight loss. Also, in people who have regained weight after bariatric surgery, this can be given for some time to put them back into track. So everything is complementary to each other. And all I want to say is obesity is best prevented. But if we do need to manage or treat it, the more options we have, the better for the patients. And of course, for us doctors also, the more options we have, the better we can tailor it to the needs of our patients.
No, absolutely. In fact, I'll emphasize that we are now accepting the fact that, obesity can even affect a lot of people who exercise regularly and who are cautious with their diet. So we are actually labeling it as a metabolic disease. But I think we need to emphasize to our patients that whether you're going for obesity managing drugs, bariatric surgeries, the emphasis on diet and exercise and lifestyle will complement all this. You cannot just get bariatric and Ozempic and think that you'll get well. You need to keep a very strong component of diet and exercise to complement all your activities. And only then will we have a comprehensive treatment of obesity.
Quite
Dr.
right.
Jayaprakashsai, any questions on the board?
Uh, Thank you, Dr. Arun Prasad, for an excellent and informative talk. There is one question. Could you walk us through how do you monitor patients when they're started on these agents? Any timelines or any red flags do you follow, or any lab tests? This was a question asked by the
Right.
audience.
So, before these medications are started, there is a standard protocol of obesity related blood tests, which we would be doing, which includes things like thyroid profile, your endocrinology profile, lipid profile. We are also looking at deficiencies of vitamin D, vitamin D, B12. So there is a standard protocol of tests which your physician, your endocrinologist or your bariatric center will do for you. Your uh, physician who's been treating you, they all know the protocol. So they will be doing all those before they go for any medications. Things like, early retinopathy, history of pancreatitis, gallstone, thyroid disease can make us more cautious in some of these patients. And also they have to be followed up very strictly. So when the medicines are started, again, there also they have to be monitored very carefully, that we start with a low dose, maybe after 4 weeks or 6 weeks, increase the dose gradually. They have to be monitored that during this period they don't develop any deficiencies, especially things like muscle loss, connective tissue loss, which is what leads to the pictures which you saw earlier in my presentation. So it has to be done as on a supervised basis. It cannot be a magic pill that you go buy from the counter and continue with it.
And most of the time, sir, if you see the trials, whatever they have done, and they have seen that stepwise titration. In real world, it's very difficult, and we need to, as you said, that we need to titrate the dose depending on the side effects, because adherence and the side effects are very important for withdrawal of the drug. I think slow titration, and I think everybody is expecting a greater weight loss by taking these drugs. I think a stepwise approach, and I think overall nutritional support, exercise, I think these are all very important in managing a obese patient, whatever.
Quite right. Actually, don't want rapid weight loss. One of the biggest side effects of rapid weight loss is gallstones, which can lead to pancreatitis. And of course, the patient suddenly starts looking 10 years older.
Yes.
So I think nutrition definitely is an emphasis, because as your appetite goes down, your intake of food becomes selective. And I think that is one parameter which needs to be monitored. And regular blood tests, you look at your lipids and you look at your kidney function test to make sure that these drugs are not, hampering any natural recovery. So that's definitely an important point there.
Sir, any experience of once they start this drug and once they stop, how do you means on a long term continuing this drug? Is there an advantage or a disadvantage of stopping the drug?
Sorry, I didn't get your question.
So patients take for 3 months, 4 months, they stop this medication, they might have lost 7, 8 kgs. And what will happen if they regain weight? Is going to harm them, or is there any benefits of whatever the weight loss they initially they had?
No, there are people who want a certain weight loss, and they feel that I just want the weight loss to start, and then after that I'm going to take over with my lifestyle changes. So if people want to do that, that's excellent. That you started the engine with the push with the medication, and then you take over with diet and exercise. That's an excellent thing, and they can come back to the medications later on if they want. But all these options are there. Plus, we all of us have very limited experience in number of patients right now. As time passes, we will be able to answer these questions better.
But I think one thing we need to, tell our patients that this is a marathon you're running. It's not a 100-meter or a 400-meter race that if you increase quickly a lot of drug, go up to maximum dose, you lose maximum weight. The weight loss is going to be gradual. One fine day, it's not going to drop 20% or 22%. It's going to be a gradual process, which will take a few weeks, months, maybe even a year or two. And the second thing is, this is a metabolic disease. So like diabetes is a metabolic disease. So you may have, especially if you're a diabetic and you're obese, I mean, this is almost your lifelong accompaniment. And the data so far, 5 years, data from an Australian group, where they said that people who had discontinued it after a year or two, when they'd achieved so-called maximum weight gain, they did regain their weight. But if they maintained lifestyle, the regain of weight was only partial. So you would, if you lost 22%, you would probably gain back 15% if you did not take care of your diet and nutrition. If you continue to do that, you might still maintain it at 20%, but some amount of rebound, regain of weight did take place.
Yes. So, in these studies, what they did was that halfway through, after achieving around 20% weight loss, half the patients they switched on to placebo, and they found that those people had gained. So if an average weight loss was about say 20%, the weight regain was around 15%. So you would still have a small amount of weight that has not been regained, and that's probably because after having lost so much weight and had the benefit of a lower weight with your lifestyle, people would get motivated to try and not regain weight. So eventually, all depends upon the motivation of the person, because after the weight loss, if they are motivated enough, they want to stop the medicines, they can stop the medicines. But if the lifestyle is not changed, then you will go back to your original situation. Because whether we talk about obesity as a lifestyle disorder or a eating disorder or a genetic disorder or a metabolic disorder or a change in genotype, phenotype, whatever genetic theories we can show. The thing is that by taking the medications, we have only altered your metabolism during that period. Once that altered metabolism has been stopped, then it's very important for you to maintain it. So that actually brings me to answer further the question which Tarun had earlier asked. So for example, in gastric bypass surgery, when we alter the intestinal physiology, the GLP-1 level it goes up, and that remains up because it's a natural GLP-1 which is being produced. And medically also we are using the same GLP-1, but here we have to either keep taking the drugs for I don't know when, or after achieving your target, you reduce the drug, maybe reduce the dose, and combine it with other modalities of weight loss, which were not working earlier. So as I said, somebody at 150 kg, they may not be able to go on the treadmill for more than 5 minutes. They'll get exhausted at that kind of a weight. But when you are 100 kgs, you are able to do much better from the exercise point of view. So when you reach 100, try and maintain it and maybe bring it down to 80 or 90.
Thank you, Dr. Arun Prasad, for, for an excellent talk. I think maintenance therapy and behavioral change is a key aspect in obesity management. I think a holistic approach is very important. I thank my chairperson also, Dr. Tarun. Thank you.
Thank you very much. Bye-bye.
Thank you, Jayaprakash. Thank you, Arun Prasad, and thank you, Gapio, for having organized this meeting. I think if there are no further questions, we could close the meeting.
Thank you, Dr. Tarun Sahni ji. Thank you, Dr. Arun Prasad. Thank you, Dr. Jayaprakash, for all your time, sir. From your busy schedule, especially on the weekend, sir. Thank you so much for this session, sir.
Thank you.
Thank
Bye.
you.
Thank you. Thank you.
Thank you.